I think I'm going to shift gears a little bit because I think this is going to be a debate among us. I doubt we all agree on this. So one of the potential practice-changing studies that's being presented is this so-called SIRFLOX study. And so it's in patients with met colon, frontline, liver dominant. Now what that meant was you could have extrahepatic disease, but it had to be small. And it had to total, only a certain number of lesions and could be nodal or small pulmonary stuff. So you didn't have to have a negative extrahepatic scan, but it had to be liver dominant. Half just got continuation of chemotherapy as you would normally, and the other half got randomized to a single infusion of yttrium-90. So the way that our guys are doing it now, learning curve for them, is they do often multiple or often two, but this was a single injection, and then resuming chemo. And the endpoint was a bunch of things, and it's, to be fair, it is one of what is a portfolio of, I think, 3 clinical trials, and it's the first one to report. So we have 2 more randomized trials to come with this essentially similar design. But the tantalizing number was that liver progression, 12 months in standard, which is what you'd kind of expect, 20 months in the patients who got the liver. Now, overall progression, not so much. What do you think?
Well, this is the problem with liver-directed therapy. Number one, up to this point in time, there's been no prospective randomized trials for anything.
Kemeny.
There have been no prospective randomized trials for anything. And I'm very appreciative of the Sirtex company for conducting and sponsoring these trials that are looking at giving everybody chemo with or without some liver-directed therapy, and they're the yttrium-90 resin beads that kind of stick in the liver and can treat liver tumors. So we know that from the data that are out there and prospective use in advanced disease with non-controlled setting, that it can shrink tumors and control the liver. So that's really not surprising. In a randomized trial, you'd see more liver control. The real question is, do you change the natural history of the disease, and are you going to, in the end, help people live longer by giving them this very expensive, very interventional therapy on day 1 of their FOLFOX chemotherapy? And the answer so far, based on the one study, is no.
So I'm going to come back in a second and ask if there's a patient you could tell me about that you might do that to. Is, a frontline patient. Rich, what's your take on it?
Well, so I believe that it's a useful tool, but it's a tool we haven't learned how to use optimally yet. And when you look at what's happened in the 80405 study that was presented last year at ASCO, where median survivals 10 years ago with the same drugs were 20 months, and now they're 30 months. Something is changing that, and it isn't that people are getting different drugs or more drugs. I think that we're understanding better how to manage people, how to incorporate breaks in therapy, but also how to use surgery, ablation, yttrium-90, in some centers, hepatic arterial infusion. I believe that all of those things can impact on the natural history of this disease, particularly in patients where liver disease is going to be the cause of their death. But that learning how to use them is part of the challenge of what we do.
So we're better chess players, but this is another data set that suggests it's a chess move we could make in the right patient.
And unfortunately, in this study, the gold standard overall survival wasn't affected, but there was a biological impact of this intervention.
Yeah.
One of my concerns with it, and I'm waiting for the longer-term follow-up, is that we know yttrium-90 can have long-term hepatic toxicity, and it's mostly been used in people who are much further along and don't have as long of a prognosis.
Yeah.
So we need to really bear that in mind, too, when we look at these data. And again, I'm very appreciative that there are now 3 prospective randomized trials of very similar design. They aren't identical eligibility, but they're close enough that we can put them together and have a very good combined analysis that will really answer some of these questions in a couple of years.
And overall survival. But will they all have hypersplenism and a platelet count of 50 when they...
And another thing is, when it comes to liver-directed therapy, do we need the radioembolization or irinotecan
Debiri,
beads,
yeah.
you know, because we saw the data about FOLFOX plus the irinotecan beads, you know, it can be, you know, exciting. The challenge, there are going to be no sponsors for prospective randomized trial, but it raised the concern about cost and long-term toxicity, so maybe that would be as good, if not better option. I'm just throwing it as a question. Yes, I've sent patients for select procedure like that. We all know which patient when we see that patient for it. So it's an option, it's a tool on the table that can be used. But we cannot draw much more conclusions at this point.
And I was thinking, sort of representing the community for us. I mean, you know, we, big hospitals, big systems, have usually somebody in IR who's who's focused on this, but not everybody's going to have that. So one of the decisions is it's going to be, you know, everybody's going to come from the farm to Columbus to get their because it is the sort of service that can be done from far away and managed. So I think it'll fall on us to sort of make those recommendations to the right patient because not every hospital, not every system is going to have this kind of, it is an expensive and technique-driven thing. The other piece is that, you know, there's a learning curve here for the IR guys too. I mean, and gals, they have favorites. You know, you get Debiri people and Y90 people and IMBO people and infusion people, and you know, it is sort of the tool of the day, the hot tool. So it is, you know, specific to your institution and your referral pattern. We have to decide some of that. Is there a favorite at Ohio State? What's your all's liver-directed therapy favorite at the moment?
Surgery.
Surgery. We're going to talk about surgery very, very shortly. Before we do that, though,